and as a clinical ear care specialist, I also specialise in the removal of impacted earwax, foreign bodies, infected debris and discharge from the ear canal. We have a lady who attended a couple of weeks ago here with a very severe impaction of earwax in the left ear, and the earwax was quite soft and mushy in consistency, and we're just at the entrance here, and I'm just trying to detach this wax from the canal wall because there is a few skin adhesions, but it was quite tricky getting a suction grip because the wax was quite sticky. It's almost like fudge. So I just thought, let's just go in with the ear hook at the top, glide in. There's a bit of an opening there, just in behind, and see if I can pry some of this wax out. And the ear hook did remove a big chunk, but it also sliced some of this soft wax. So I then went in a moment with a Jobson horn, I believe. So you can see we can really dissected this wax, so a bit deeper in the ear. Bit of a gap just at the top. Because the wax is a bit softer, we can sometimes use these instruments deeper in the ear, because if the wax was hard and we're trying to insert an ear hook or Jobson horn deep into the ear, you're going to make contact with the canal wall, the bony part, which is the inner 2/3, which is very sensitive. But when the wax is soft, you can obviously glide in and compress some of this soft wax down, so you don't have to make contact with the canal wall. So we're just using a Jobson horn here. Sometimes they're called an ear correct or an ear spoon. And I just took a large piece of wax there, but it's quite sticky and it's stuck to the base of the ear canal. So let's just remove this tailing piece of soft wax that's almost hanging out of the ear. Again, just inserting this Jobson horn. It was slightly a tedious procedure because the wax was, as I said, soft, and in a way you hope when you use these instruments you get into the wax and you extract it in one big piece, but it wasn't the case. So we're just doing layer by layer of earwax, and I decided just to put some drops in there to change the consistency, because and go back in with the Zollner suction probe, because it might have made the removal a bit quicker and easier, sort of trying to use an ear hook and Jobson horn layer by layer. So you see a bit of keratin that we removed, so a bit of dead skin, and I'm just going to peel this keratin off the base of the ear canal. And in everyone's ears there's a bit of a blind spot, so as you enter the ear canal to the rear, there's a bit of a hideaway there where you can get buildup of wax, and it's important to try and remove any wax from that blind spot, because quite often there's a bit of keratin dead skin and you can remove it from that blind spot. So when we enter the ear canal, it's to the rear, so to the back part of the ear canal on both sides. And if you can remove some dead keratin from that blind spot, it just makes the rest of the procedure a lot easier. So the wax is a bit sticky still. Just trying to peel this off the canal wall, some of the skin, but we just have to be careful that we don't make contact with the canal wall. You can see the wax is also quite elastic, so it's the skin, so when I'm peeling it you can see it stretch. It's probably one of the, it's not a complex type of wax remove, it's just one that I don't really enjoy doing because it's like wet mud almost, and it keeps blocking the tube, and you're sort of pulling the wax out, you're stretching it into long pieces, and it just takes a bit of patience as well. But I think in a minute, because that was also quite tedious, I'm just going back into the Zollner suction probe, but I'm just going to use a Jobson horn in a moment, I think, just to go in behind. So I try wherever possible to avoid using a Jobson or horn or an ear hook when we're going deep in the ear, because you always do run the risk of making contact with the ear canal. On the outer part, as I said earlier, the wax is soft, so we can go in and push the wax down, but further in the wax is completely compressed, so there's very minimal opening. But there comes a time in the procedure where you think, well, I can do this all day and it's just not going to come out. So the moral of that basically is I always try and do the safest procedure, and when you're deeper in the ear, the safest technique, other than the noise, the suction is quite noisy, is vacuuming the wax out, because you're less at risk of making contact with the ear canal wall. And you've probably heard me saying this in quite a few of my videos, even the ones I've uploaded today. I hate making contact with the canal wall because it can be very uncomfortable for the patient, and the patient's comfort is my main priority. Even if it means taking a bit longer in the procedure to remove the wax, I'll rather that than cause any discomfort and pain to the patient. And hence why sometimes I persevere a bit more with a particular instrument, so in this case obviously suction, just in the hope, let's see if it does come out, because sometimes you can give up a bit too early, and if you continued a few more seconds or half a minute longer, it would come out. But I've got this intrinsic feeling now, I think, well, okay, it's just too mushy. You can see I'm just stretching the wax, I'm not really moving it out. So at this point I've evaluated it, I thought I've got no choice now but to use other instruments, and it does make it a bit more riskier. You're more likely to cause a bit of discomfort, but you've got to weigh it out. If I went in straight away with an ear hook or Jobson horn, where actually if I persevere with the Zollner suction probe, then I'd be causing the patient unnecessary undue pain. But I'm just gliding at the top, and I'm just pushing this down, getting in behind, pulling this big plug forwards. But you will see it's a large piece of wax that I've removed, but there's still a massive plug deep in the ear. This is a bit more challenging to use, the instruments, because you do get a bend in the ear canal, a second bend, and the ear canal does also narrow the isthmus, which is a narrowing of the ear canal about 1 centimetre away from the eardrum. So I'm just going back in with the Zollner suction probe because, as I said, it's a lot more trickier to insert these instruments deeper in the ear past these bends, because the instrument itself is not bended. It's made of carbon fibre, although it is pliable. Obviously, if I insert that straight in, it's going to touch the back canal wall. It hasn't got a natural U-bend, which is something maybe I can develop some more custom design instruments where we can accommodate for the bends and twists in the ear. So, and this is a bit of an example. So I'm just using an ear hook, and I got a piece of wax out here, but I think I'm going to go in an alignment with the ear hook. But the bend on the front part of the ear canal just restricted me getting the hook where I wanted it. So it's just a gap there. I just want to insert it through that gap. And as I'm putting it in, you can see there's not enough space. That bend is preventing me from getting that ear hook in. The back part, the L bend of the ear hook was touching the anterior canal wall. So this is something I've not really done before. I've just soaked the ear. Normally I let it soak for 5 minutes and I drain it, but this time I haven't. I've just put the drops in. The patient's held tilted to one side, and as the drops is in the ear, I'm just trying to suction this wax out at the same time. Now, normally, if you get the patient to tilt their head back into a normal position and you vacuum, you'll see a lot of blurriness because you're sucking the oil out. But I've got this patient's head tilted to the side, so the ear that we're performing the procedure in the left ear is actually facing the ceiling, and I'm actually almost standing up and doing this whilst the patient's head's tilted. So, and I found that it doesn't blur the endoscope, because obviously if it's very blurry, you can't really see what you're doing, so it's not safe. But this worked really well, and I use olive oil, as most of you do, as a bar of soap. When you've got a ring stuck in your finger, you put a bit of soap, a bit of lubrication, voila, it comes out. And this is a huge piece of wax that's come out there, and you'll see it on the tissue. You can compare it to the rest of the chunks I removed. There's a tympanic membrane, intact, light reflex, maybe slightly retracted, a slight attic retraction there, just mopping up near the entrance. And you'll see a still image of that large piece of wax that I removed in comparison to the rest. You can see the bends and twists in the ear canal there. That was a good shot where you can actually visualize the first, second and the third narrowing the isthmus. So there's that big chunk of wax, bottom left of screen. I hope you enjoyed that video, guys. I'm going to try and upload one more before I call it a day. I hope you're all having a nice Saturday evening, wherever you're